right, we are at 12 p.m., so we will go ahead and get started. So thank you for joining us today for this Upper Midwest Telehealth Resource Center webinar. My name is Cameron Hilt, and I serve as the Program Director for the UMTRC here at the Indiana Rural Health Association. And I want to welcome Nicole Watkins, who is the Rural Health Clinic Network Director at the Indiana Rural Health Association, who's been working on maternal and child health grants for over the past 3 years, who's going to give us a little bit more information on the community paramedicine program and bridging the OB gap. So I'll go ahead and hand it off to Nicole. Thanks, Nicole.
Good afternoon, everyone. Like Cam said, my name is Nicole Watkins, and I have the pleasure of working on IRHA's community paramedicine program. And so often there's just a large gap that exists between the physician office and the patient's home. Sometimes education is given, but it gets forgotten or lost, or sometimes it's hard for patients to even get to the physician's office for regular appointments, let alone additional services as needed. So today we're going to explore the innovative model of community paramedicine and how it not only bridges this gap, but it also connects the feedback loop from the patient's home back to the physician's office. So let's start by looking at the needs of rural Hoosiers. So this slide shows where Indiana is at as of 2019, which is the most current data available in terms of a few measures of maternal and infant health. I'm sure you all are aware of some of these, but just to clarify, the infant mortality rate is infant deaths that are less than 1 year old. Maternal mortality rates are deaths from pregnancy and childbirth. Preterm is defined as births at less than 37 weeks gestation, and then low birth weight is infants weighing less than 2,500 grams or 5 pounds, 8 ounces at birth. Indiana has really been on the forefront of many maternal and child health innovations, but it also has a long road ahead to improve these metrics. Rural Indiana has always had unique challenges and would especially benefit from community paramedicine. Rural areas often experience OB deserts, where there is no facility nearby that has an OB department, transportation barriers, which can lead to missed appointments or forgotten care, and then just generational misinformation and higher adverse outcome rates. So just an example of generational misinformation and what I mean by that, which can come from a lack of education on the most recent standards of care. As you all know, healthcare is forever and always changing very quickly. So there may just be some lack of education. So for example, a grandmother may advise her daughter that she can put her baby to sleep on her stomach because that's what she did for her and she survived just fine. But now the standard is the ABCs of safe sleep, which is alone on their back in a crib. So all of these challenges contribute to the necessity for home-based and patient-centered care. So this is just a visual for you of an OB desert map by the Indiana Hospital Association. So all of the dark gray counties are counties without any kind of hospital, and all of the light gray counties are counties without inpatient delivery services available. So as you can see, particularly the central northwestern side of the state is an OB desert. These deserts can cause patients to forego care or have to drive long hours to receive basic care, let alone specialty OB care. This can cause problems for pregnant women, but especially those with high-risk pregnancies. So now that we can literally see the need here on this map, let's shift our focus over to defining community paramedicine and how it can serve rural women. So first, to understand what community paramedicine is, we need to first start with defining mobile integrated health, which is a patient-centered model of care delivered in a patient's home or in a mobile environment. So community paramedicine is a form of mobile integrated health. Mobile integrated health can include other aspects such as social work, substance abuse, mental health, and chronic disease management. Mobile integrated health and community paramedicine fall under the jurisdiction of the Indiana Department of Homeland Security, just in case you were wondering. And for our community paramedicine program, we chose to focus on obstetric care. So the Obstetric Community Paramedicine Program offers prenatal and postpartum care for at-risk women and their babies with the goal of improving health outcomes. In this program, paramedics with additional training, known by our program as community paramedics, they act as physician extenders. So our community paramedicine program seeks to base our model on the current Crawfordsville model, which is locally known as Project Swaddle, but with changes tailored to each community. So currently there is not a national or statewide standard for community paramedic training. While this is in process of being set at the state level, we have allowed hospitals and their staff to decide what education is most needed for them to best serve their community. So this is a list of recommended trainings for community paramedics. It is not exclusive, it's not exhaustive, but these are just some that have been recommended by the Crawfordsville model. Following along with that, we have a list of services. Community paramedics make in-home visits with the mothers at varying frequencies throughout the pregnancy process and during a set time following birth. So during their visits, community paramedics can provide a variety of services, including but not limited to, again, the services listed on this slide. Again, we have let hospitals and community paramedic staff decide what services they're comfortable providing and that they're able to provide. This slide here just outlines the workflow between program partners. It is recommended for hospitals and their respective EMS services to execute a flat fee-for-service contract where the hospital pays the EMS service a lump sum to support their services. So this model is recommended just to foster transparency and to ease the billing process. EMS cannot currently bill specifically for the services that they provide, but the hospital can, which is why this helps with reimbursement to keep the flow of funds going. The patient's physician orders community paramedic services, and the hospital contacts the EMS to provide the ordered services. So then EMS is then dispatched at the scheduled time to the patient's home, and then they document thoroughly in the hospital's electronic medical record, or EMR. So like I said, the hospital bills for any eligible services provided by EMS as documented in the EMR. And the EMR is the vector that closes that feedback loop between EMS and the hospital, just to provide the highest quality of care with the most up-to-date patient information. With the hospital, city, county, and EMS service all investing in community paramedicine financially and through resources, more women and infants can be reached with additional services that they may have originally foregone and increased access to care. So telehealth, which is of course the subject that interests all of you the most. Telehealth can be used in community paramedicine. We are currently not using it, but we hope to expand in the future once our programs get off the ground. So EMS vehicles for community paramedicine have been outfitted before with telehealth equipment, and that can be used in a variety of ways depending on what specialty is chosen for the community paramedicine program. So for our program with obstetrics, telehealth can be used for communicating with OB providers or connecting patients with community paramedics if a home visit is deemed as unnecessary. Other potential programs such as cardiac or chronic disease management could use telehealth to communicate with specialty providers or send information to the EMR. It could also be used for remote patient monitoring as well. So now that we know what mobile integrated health and community paramedicine are, let's move to talk about IRHA's program, Maternal and Child Health Community Paramedicine. So to address these issues in Indiana, IRHA, the Crawfordsville Fire Department, and United Healthcare have come together to create the project team. IRHA is providing project management, Crawfordsville Fire Department is providing expert technical assistance, and United Healthcare, through their foundation, has provided seed funding for each hospital partner. Hospitals are using this funding to hire paramedics, train current paramedics, purchase a designated community paramedicine vehicle, or any other expenditures that will help them reach their goals within community paramedicine. With input from the Crawfordsville Fire Department and United Healthcare, IRHA is working with Parkview Health currently and Good Samaritan Hospital in Knox County, and we're in process of adding a third hospital as well. We've collected specific documents from our partners that would legally allow us to share data, add them as a sub-awardee, and outline roles and responsibilities. So once we had these documents, we planned a kickoff meeting. Hopefully it would be in person, but we all know that that situation is always changing as well. We also schedule recurring partner meetings for updates and progress reports, and then partners submit invoices quarterly, and then we also provide reports to our funder, which is the United Healthcare Foundation, quarterly as well. So as we have been building this program, we've identified several keys that we feel are vital to this program succeed. First, you need a partner EMS service, either public or private, that is willing to provide community paramedicine services if they're not already doing so. And they also need to be willing to learn how to document in the hospital EMR system. You need a hospital with buy-in from its leadership. So this could include the ACO director, the CEO, COO, CFO, director of physician services, OB director. You just need a hospital that will allow community paramedics to access its EMR as well. Then you also need buy-in from the city, such as the mayor's office. This is something that will affect the city as well, and we'll talk about that next. So with any new program, partners often ask about the benefits. If they're going to contribute time, resources, staff, and funds to a program, the benefits must outweigh the costs. Hospitals can benefit from an OB community paramedicine program because it could lead to improved health and quality outcomes, avoided NICU stays, which have an average cost of $150,000 per week, decreased preterm births, decreased low birth weight babies, decreased length of stay for neonatal abstinence syndrome born babies, decreased hospital length of stay for women, and decreased DCS involvement as well. Hospitals are penalized for certain outcomes, such as avoidable days, and are known for infant mortality rates, preterm birth rates, and low birth weight rates. Improving these outcomes and rates can lead towards a more positive reputation within the community, county, and the state. Cities and counties can also benefit from a community paramedicine program due to healthier women and children. The health of residents is often a consideration of new businesses looking to expand into new areas. An OB community paramedicine program also increases education and can reduce missed work days with the program's full integration into the healthcare system. Healthier women with healthier full-term pregnancies recover in a shorter time period than those with complications. So support for pregnant and postpartum women and children can also help to increase the population of a city and county. And this also supports numerous aspects of the economy. EMS services can benefit from a program because it can prevent emergency deliveries by EMS personnel. It can improve 911 staffing levels, improve the expectation of care, and extend career longevity. Staffing is always difficult for EMS services, especially when rural counties are required to have a specific number of ambulances and EMS personnel in the county at any given time. So by using community paramedics and a designated community paramedicine vehicle, ambulances and 911 personnel can be reserved for emergencies instead of transporting women out of a county to a hospital with an OB department. This also provides a relief for the burden of 911 capacity. The role of a community paramedic has often been filled by retired or close to retirement age EMS personnel. This extends their career by providing a less physically demanding, less rushed, and reduced stress role. So this is a unique role that adds value to their career and increases professionalism. Community paramedics build relationships with hospital staff, city and county leadership, patients, and the patient's family. This program also can reduce cost of ambulance fuel, staff time, and wear and tear by utilizing an SUV instead of a truck. On average, one 911 call costs $1,000 and uses 6 EMS personnel to staff a fire truck and an ambulance. On average, one community paramedicine call costs about $500 and uses 2 community paramedics to staff an SUV. The Crawfordsville model has proven effective. Through replication, we seek to show that our similar model is also effective and should be reimbursed. Currently, the Crawfordsville model is funded by the City of Crawfordsville, Franciscan Health, and the Crawfordsville Fire Department, and then also grants. The ability to bill for community paramedic services would allow for expansion of services. To keep stakeholders involved, we created an advisory team with representatives from FSSA, the Indiana Department of Health, Indiana Department of Homeland Security, QSource, InWell, and Mental Health America, Indiana. The purpose of this group is to provide guidance for the program and to brainstorm solutions as barriers arise, and then also to keep all the stakeholders informed and involved in the process of the program and the outcomes of the program. So we are collecting data from our partners to qualitatively show that the program improves health outcomes. We'll also be conducting a cost-benefit analysis to show the financial impacts of the program. So this is a non-comprehensive list of data elements that we plan to collect. This data will allow IRHA to conduct the data analysis and then provide feedback to our funder, as well as measure progress towards our specific program goals. So what's next for community paramedicine as a whole? Through our advisory team, where we have multiple state level representatives, we are working to organize statewide. We want to get all maternal and child health organizations together so that we can complement each other's services without duplication. We are seeking to construct criteria for community paramedicines to be state approved to allow for standardization and regulation of programs. We are also looking to define what a community paramedic is, their scope of practice, and what training is required to become one. So this is my contact information here if you would like to reach out, but I am happy to take any questions that you may have at this point. I think I see a couple here in Q&A. All right, let's see. The first one here looks like, is there an opportunity to support smoking cessation with paramedicine? Has this been done? I am not sure if Crawfordsville is currently doing this. They have so many different programs, it's almost hard to keep track of them all. I do believe that you could do smoking cessation with paramedicine. Community paramedics are trained to do health education, and this could certainly be part of that. They can also link them with community resources that could help with smoking cessation as well. They also may be able to help with insurance. And if they don't have insurance, they could link them up with insurance, or they could help work with their insurance to get them any kind of medication or patches or things like that that could help with smoking cessation. All right, have these community paramedics given vaccinations, both COVID and infant immunizations? I am unsure about COVID. I do believe they have given infant immunizations. Again, this is where especially transportation barriers can come into play when moms can't get their babies to their well baby visits. Paramedics are definitely licensed and able to give vaccinations. And this could be a huge, huge plus for communities, especially just with the push, not only for COVID, but also for vaccinations in general, to be updated with adults and children. Are community paramedics trained to perform phlebotomy services? Again, there is no standard there's no standard training for community paramedics yet. That is something that the state is working on, and we are very excited to be at the table for that. I don't see why they couldn't. There would probably just need to be some kind of agreement or relationship with a lab, whether that's at a hospital or an independent lab, to get those services done. Again, it depends on what specialty you'd like to focus on. So we did obstetrics, you could do family medicine as well. So I think that's definitely a possibility. Again, it just depends on what the hospital and the paramedics are comfortable with performing. Right, can you get a copy of this slide deck? Of course you can. I love that this could be a resource for you in the future. So I will send that over to Cam or Carolyn, and we will get the slide deck sent out to you.
Is there any more questions for Nicole while we have her here? I'll ask one, Nicole. So what do you think is some of the outcomes that people are really hoping to see through this community paramedicine program?
Through ours specifically, since we're focused on maternal and infant health, we would really like to see, increased birth weights. So infants that are more than 5 pounds, 8 ounces. We'd love to see full-term pregnancies. We would love to see just a relationship develop between moms and their families and these community paramedics, who are really just trusted providers in the community that are there to help you, and they are there to answer any question. There's no questions that are too big or too small. So just we'd love to see that relationship grow, and we'd ultimately just love to see healthy moms and healthy babies, and that is the ultimate outcome. That is a win-win for everyone involved.
Well, thank you, Nicole, for joining us today. I just want to point out real quick here that we do have a event survey that was just posted in the chat. Please take a moment to fill this out. This helps us to know just what were some things that you enjoyed about this presentation, what are some takeaways you have from it, as well as if there's future topics you want to see us cover in our webinars in the future, that's your chance. As well as if you have any questions for Nicole, feel free to submit it on that survey. We'll ensure that you are connected to her. And just as a reminder as well, this recording and slides will be posted on the UMTRC archive webinar page. And so you will be able to receive those slides through that as well. So thank you so much for joining us, and I hope you enjoy the rest of your afternoon.